Thank you all for joining us for today's webinar, Rheumatoid Arthritis in the Female Patient, Reproductive Health Considerations. My name is Jessica Monmany, and I'm the Senior Education Associate at ARHP. I will be moderating today's webinar. Before we begin, I would like to share how you can receive continuing education credit for this webinar. In order to receive credit, you must take the pre- and post-test. If you have not yet taken the pre-test, please click the link provided to you in the reminder email or via the webinar's chat box. You are also welcome to use the chat and question box to ask questions throughout the webinar, which our presenters will answer at the end. About an hour after the conclusion of the webinar, you will receive an email from Caitlin Borsowitz, ARHP's Communication and Education Associate, with a link to the post-test survey. Your continuing education certificate will be generated upon completion of that survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you've incorporated what you've learned during this webinar into your work. Completing the pre- and post-test, as well as this follow-up evaluation, helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce Drs. Mary Hebert and Megan Close, today's presenters. Mary Hebert is Professor of Pharmacy and Adjunct Professor of OBGYN, Director of the University of Washington Obstetric Fetal Pharmacology Research Unit. She is a Fellow of the American College of Clinical Pharmacy. Dr. Hebert received her PharmD degree and completed her clinical pharmacy residency as well as fellowship at the University of California, San Francisco. She has 26 years of experience conducting clinical pharmacokinetic and pharmacodynamic trials resulting in 100 publications. She's been an invited speaker at many national and international conferences. Her research focuses on the pharmacokinetics and pharmacodynamics of immune modulators in solid organ transplantation and the clinical pharmacology of medications in pregnancy and lactation. Her current work in obstetric fetal pharmacology focuses on the mechanistic basis for clinical pharmacologic changes in medications of therapeutic value during pregnancy. Megan Close is a clinical researcher with a focus on the management of rheumatologic diseases in pregnancy. Since 2007, she's collected prospective pregnancies in women with rheumatic disease in the Duke Autoimmunity and Pregnancy Registry, which currently includes over 425 pregnancies. This registry includes clinical data, pregnancy outcomes, and a large sample repository. Dr. Close has also conducted numerous studies on the impact of rheumatic diseases on pregnancy and fertility, including the Vasculitis Pregnancy Registry through the Vasculitis Clinical Research Consortium, an online pregnancy registry for women with these rare conditions. Dr. Close is also studying causes for the high rate of infertility among women with rheumatoid arthritis. She's also working to better understand how psoriatic arthritis impacts pregnancy. Our presenters' full bios are available on ARHP's webinar web pages. We're thrilled to have them with us today, and I will hand it over to Megan. Megan, you have the floor.
Thank you, and I really appreciate the invitation to participate in this webinar, and I'm thrilled that so many people have signed on. So today we're going to be talking about management of reproductive health in women with rheumatoid arthritis, and where some areas are a little bit different than women that you might see on a more daily basis. So first we're going to discuss sexual and reproductive health issues for women with rheumatoid arthritis. Next, we're going to review contraception as well as preconception counseling for these patients. We're going to discuss in depth the different medications and best practices for management of rheumatoid arthritis with these medications both during pregnancy and during breastfeeding. And then we're also going to be talking a bit about counseling patients with rheumatoid arthritis regarding the risks and benefits of treatment during pregnancy and lactation. And we're going to finish up with, this presentation with a case that hopefully will help you apply the things that we've talked to you in more didactic form. So I think we all need to start off with making sure we're on the same page, and that is, what is rheumatoid arthritis? So rheumatoid arthritis is a chronic inflammatory disorder. It's a classic autoimmune disease. It affects particularly the small joints of the hands and feet, but also can affect the elbows and shoulders, knees, and wrists. It particularly happens in women, so about 2 out of every 3 patients with rheumatoid arthritis is a woman. The typical onset is in the 40s, really, is the most classic. Certainly it happens who are older, but it also happens in women who are younger. So many of them will have issues of their reproductive health coming up after a diagnosis of rheumatoid arthritis. I should add that when we talk about rheumatoid arthritis, we include in that, particularly for this discussion, women who are now grown up but started having arthritis, inflammatory arthritis, when they were children, what we call juvenile rheumatoid arthritis, or JRA. The same principles that we're going to talk about today really apply to them. So it's a classic autoimmune disease, which means the immune system is attacking the joints. We really don't understand what the clear triggers are. There's clearly some genetic component, probably some environmental, perhaps some infectious. We really don't know what triggers the beginning of rheumatoid arthritis, but we know a lot about how it progresses from there. And we know that without good medications, patients end up with a lot of disability, bone erosions, joint deformity, and so on. But we're really blessed with new medications in the last 15 years or so that have really changed the course of rheumatoid arthritis for a lot of our patients, so that the crippling arthritis that we used to see really is not the norm anymore. So the first thing to talk about is contraception. And when we talk about contraception, it's important to realize how common unintended pregnancy is really in the U.S. and worldwide. Worldwide and for decades, really about half of all pregnancies are unplanned. Not necessarily unwanted, but that many of them are unplanned, and that rate has actually gone down a little bit most recently, probably with the better birth control options. But who has unintended pregnancies really varies by socioeconomic status a lot. This slide here tells us that the people who live below poverty have much higher rates of unintended pregnancy compared to those that live significantly above the poverty level. And the sort of average rate is 45 unintended pregnancies per 1,000 women. So fortunately, as I said, there's really good birth control these days. It's really different than what we used to see. This is something that I'm sure that all of you are well versed in, is the new developments in long-acting, reversible, or LARC contraception. There was a nice study that was published in the New England Journal a few years ago that I think was really eye-opening to a lot of people who were not in the field, and that they saw that the rate of teen pregnancy in young women who had been offered LARC for free decreased by 20-fold compared to women, young women who were on either pills or patch or ring. So a huge difference in avoiding pregnancy with the use of things like the implants and the IUDs. So I think this is really important to keep in mind, and to keep in mind that these are largely appropriate for our patients with rheumatic disease. So you may be familiar with the CDC's general guidelines about contraceptive use. They were been updated quite recently, actually. So the way that this table works is Category 1 recommendations are basically any kind of contraception that you really can use without restriction in this patient population. Category 2, still the advantages generally outweigh any sort of theoretical or proven risks, but you have to be perhaps a little bit more cautious and perhaps have a little bit better follow-up. So with rheumatoid arthritis patients who are not on immunosuppression, that's the group here in the bottom, they can be on, and really all the patients can be on progesterone-only pills. Those are considered fine. Implants are considered fine, as well as both the progesterone-containing and the copper IUD. So all of these can be used without restriction in all of these rheumatoid arthritis patients, whether they're on immunosuppressive therapy or not. So I think that's really good news, that our long-acting, most effective contraception can be really used without hesitation in these patients. Category 2, so sort of when there might be a little bit of concern, and I will tell you that this concern is extraordinarily low in my mind, is using something that contains estrogen. There's really no data that suggests that estrogen drives rheumatoid arthritis activity, though some patients believe that it might. That's really very anecdotal at this point. Long-term use of the injection, like Depo-Provera, for example, can be associated with osteopenia and bone thinning for patients who are on long-term prednisone, which unfortunately some of our rheumatoid arthritis patients are. They might have a higher risk of osteoporosis with that. So we generally don't like to use Depo-Provera for more than 2 years in this patient population. And then there is some theoretical risk of infection with the placement of an IUD for a patient who's on strong immunosuppressive therapy. I personally don't let that stop me from having a patient get an IUD placed on immunosuppressant therapy. The risk is minimal, and if they're particularly concerned or the patient is very prone to infection, they could perhaps some prophylactic antibiotics. So counseling tips for women with rheumatic diseases and contraception probably can be applied to really most of our patients. Number one is really active listening, and I would consider sort of active questioning to really kind of get to what the goals are for this patient. Does she really just not want to be pregnant at all ever again, in which case either long-acting reversible or even surgery might be appropriate. Is she contemplating pregnancy, something that she wants in the next few years? Does she want something that she can take every day? How reliable is it? Does it really need to be? Is she open to being pregnant? Is she terrified of being pregnant? So sort of figure out really where she is. And then sharing information with her, which I'm going to show you in the next slide, and a tier-based chart to really show what's most effective versus what's less effective. Ideally, if you can provide hands-on models or pictures, or really give people a better sense of what an IUD really looks like, what an implant really looks like, that sort of thing, I think can be really helpful. And then avoiding being directive and too paternalistic and just telling women what they have to use rarely works. So the tier-based approach, so the most effective things are implant, vasectomy, sterilization, IUD. These are all lead to less than 1 pregnancy per year out of 100 women. Next is the injectables, pills, patches, etc., followed by condoms, the withdrawal method, etc. So I think it's useful to really show this to patients so they get a sense of, oh, I'm down here in this less effective range, but I really don't want to get pregnant. I probably need to move on up the lists. So this is our first polling question, and we would love to have a lot of you participate. So the question is, true or false? Rheumatoid arthritis often improves in women during pregnancy. So answer true or false. Rheumatoid arthritis often improves in women during pregnancy. Once we get your answers, we're going to show it up here in just a minute. Excellent. Is that everybody? Excellent. So 69% of you said true, that rheumatoid arthritis improves in women during pregnancy, and 31% said false. So 69% of you are on the right track, but perhaps not as on the right track as we used to think. We do think that, I'll have to push the button, sorry. We're going to get to it in a few slides, but we do think that rheumatoid arthritis improves to some extent in pregnancy. So first we're going to talk about fertility. So rheumatoid arthritis actually does appear to have an impact in fertility in a lot of patients. There's actually data going back to the 1960s showing that women with rheumatoid arthritis have fewer children than their neighbors do. And interestingly, even women who are diagnosed in their 50s and 60s with rheumatoid arthritis have had fewer children over their life than their neighbors. So there seems to be something with fertility and rheumatoid arthritis. A really nice study was published a few years ago that was following women with rheumatoid arthritis who wanted to get pregnant because the study was actually interested in their pregnancies. But what they found was that a huge number of women didn't ever get pregnant, or that it took them a really long time to get pregnant. So then they were able to really sort of figure out what contributed to the delay in pregnancy. So the most obvious thing is increased maternal age. We all know that as women get older, it's harder to get pregnant, so that's not surprising. Nulliparity, so never being pregnant, also probably because you might have some infertility there as an issue. But I think two things that are really interesting is that patients with more active rheumatoid arthritis really struggled to get pregnant. And then patients who are taking higher doses of prednisone, so more than 7.5 milligrams a day, which isn't really all that much prednisone, had really hard time conceiving, as did women who were taking NSAIDs. So there is some data suggesting that NSAIDs, like ibuprofen and so on, actually can prevent or inhibit ovulation, so it makes sense. But the prednisone and the disease activity was not really known before. And I think it's important for us to keep in mind, it is not uncommon for me to see a patient who has decided that she wants to get pregnant, and so she stops all of her rheumatoid arthritis medications, and then she shows up to my clinic 2 years later and she's still not pregnant, and she's now suffered a lot of joint damage and been really miserable for 2 years and is ready to throw in the towel. And then once we get her on appropriate medicines, actually can conceive. So this is, I think, eye-opening, and I think it's worth considering, particularly for our patients who are older, who want to have a baby, that letting their disease flare might not be useful for them. So it really highlights, as it says here, the importance of disease control while avoiding teratogenic medications. Preconception planning is something that is something of a luxury, but that we sometimes do get to do with our rheumatoid arthritis patients. They actually tend to be pretty good about wanting to talk about their treatments and how to be prepared for pregnancy, in my experience. So rheumatoid arthritis often does actually improve during pregnancy. We think that this is from immunologic shifts, so that when you are when you're pregnant, right, if you have to change, your immune system has to change so that you don't reject the baby, right? If we were to just take your husband's kidney and put it in you, you would reject it, but you can take a fetus that is half your husband's antibodies or antigens and so on, and you don't reject it. So your immune system shifts during pregnancy, and we think that that shift means that you also stop attacking your joints to some extent. So rheumatoid arthritis appears to improve. This has been known for decades. And then it often flares after delivery. So in my experience, about 4 to 8 weeks after delivery, the rheumatoid arthritis comes back pretty dramatically at that point. We also think that women with active disease during pregnancy have higher risks of preterm delivery, as well as small for gestational age babies, that compared to women whose disease is well controlled during pregnancy. So it sort of gives us the idea that the risk of leaving active inflammatory rheumatic disease, and rheumatoid arthritis accounts in this, of the mother untreated for 9 months has to be weighed against any potential harm from drug exposure from the fetus. This was said by the European Rheumatology Group. They just recently had a task force that made really strong recommendations, helpful recommendations about medications, which Mary's about to go over in just a moment. And I think it really drives the point home that allowing women to flare and have active autoimmune disease during pregnancy can really be harmful, and potentially can be more harmful both to the mother and the baby than having her on quite safe medications. Preconception, the issues are similar for our patients to others, but also include making sure that you rebalance the medications so that you stop her teratogenic medications and get her on safe medications, and that you make sure that everybody, this is often one of the hardest parts, everybody on the team is on the same page. So the patient and the rheumatologist and the obstetrician and the primary care doctor and everybody else in between is actually on the same page can be a real challenge. It poses a huge challenge for patients who get different opinions in different offices every week. But it's important to get everybody on the same page, including the pharmacist, who can also provide really valuable information. And sometimes that just requires a phone call. Sometimes it requires sending notes back and forth. But it's really helpful to the patient to get everybody on the same page, ideally prior to conception, so that her medications are really stable when she walks into pregnancy and she knows what the plan is going to be. And with that, Dr. Bear is going to take us through medications in pregnancy.
Good morning to those of you on the West Coast, and good afternoon for those of you farther east. It's my pleasure to be here today and talk to you about drugs used to treat rheumatoid arthritis both during pregnancy and lactation. When we're considering the use of medications during pregnancy or during lactation, it's important that we weigh the risks versus benefits. I'm sure you're all aware that the FDA pregnancy categories, the A, B, C, D, X category system, really did not correlate well with the safety of medications during pregnancy, and so the FDA has removed that system, and really we need to be relying on information that's actually known about drugs during pregnancy. When considering rheumatoid arthritis treatment during pregnancy, it's important to strike a balance between the risks for disease progression without treatment and the risks of pharmacotherapy during pregnancy. It's hard to generalize rheumatoid arthritis progression over 9 months if left untreated. Some women have aggressive destructive rheumatoid arthritis that will show progression over a 9-month period during pregnancy, while others have a more benign course, irrespective of pregnancy, that may not show radiographic progression over several years. Deman et al. Has shown that 50% of women have moderate to high disease activity in the 3rd trimester of pregnancy. If they weren't pregnant, they would be treated aggressively with escalating medications to try to improve disease control. In pregnancy, consideration of a similar approach with cautious use of medications is reasonable. Moderate to high rheumatoid arthritis disease activity is unacceptable even during pregnancy for 3 reasons. Physical well-being and function of a patient is severely compromised with active rheumatoid arthritis. Second, there is good data that systemic inflammation, irrespective of the cause, can increase the risk for adverse fetal outcomes, including prematurity and low birth weight. And lastly, joint damage progression is much more likely when disease is uncontrolled. Despite recent advances, we're still unable to predict which women will improve, stay the same, or worsen their underlying rheumatoid arthritis during pregnancy. We need to approach each woman with the goal of treating the underlying disease with the target of the lowest disease activity safely achievable. Over the next several slides, I'm going to talk about tables, and within those tables are pie charts that have come from the European League Against Rheumatism guidelines. The colors that make up the pie charts are expert opinion as to how they would use the drugs during pregnancy, with blue being they would use the drug the same way as if the woman was not pregnant or not lactating when we get to the lactation section. Yellow is that the expert would only use the drug if they thought the patient would have moderate disease, if or worse, if the drug was not given. Red is the drug would only be used in severe disease if the drug was not given. And then black, the expert wouldn't use the drug during pregnancy. This table shows a summary of the overall risks of the most commonly used non-biologic agents for rheumatoid arthritis. Methotrexate's first on the list. Methotrexate is a folic acid antagonist and is associated with increased risk of malformations. When it's used during organogenesis, which is typically people talk about it as the 1st trimester, although organogenesis generally is over by 10 weeks. It is associated with multiple congenital defects referred to as methotrexate embryopathy. Although not universally accepted, the critical period of exposure is suggested to be 8 to 10 weeks post last menstrual period, or 6 to 8 weeks post-conception, with the critical dose being greater than or equal to 10 milligrams per week. However, I will tell you that methotrexate embryopathy has been reported with doses of 7.5 milligrams per week. Exposures in the second and third trimesters have been associated with fetal toxicity and mortality. Because of the long tissue half-life of methotrexate, most providers recommend a 3-month washout period prior to conception. Next on the list is leflunomide, and there isn't really any information on leflunomide during pregnancy. Sulfasalazine, most human reports on sulfasalazine during pregnancy have not been associated with adverse pregnancy outcomes. And if you look at the table, the pie chart, approximately 2/3 of the experts would use sulfasalazine up to 2 grams per day in the same way as in the non-pregnant population. Hydroxychloroquine is a drug that is commonly used during pregnancy and throughout pregnancy, and is not considered to be associated with malformations with more than 400 exposures. And you can see from the pie chart the vast majority of experts would use it throughout pregnancy as if the patient was not pregnant at all. Preliminary data on the TNF-alpha inhibitors during pregnancy is quite promising. Placental transfer is low, and there's no clear pattern of malformations reported. Of note, I will say that in the latter part of pregnancy, there is antibody transport across the placenta. Most experts do reserve these agents for patients expected to have at least moderate disease in their absence. It's unclear at what point during pregnancy the drug should be discontinued, however. This hasn't really been studied. In the pharmacokinetic world, when we're trying to figure out how long do you have to go before the vast majority of drug is gone, we typically say at least 5 half-lives. Excuse me. If you look at the half-lives for these drugs, etanercept is the shortest at 4 to 5 days, with the others being approximately 2 weeks. So if you go 5 half-lives, depending on the drug, you may want to wait. You may want to discontinue the drug prior to pregnancy so that all the drug is gone. Some experts, however, will continue these agents all the way through pregnancy, others discontinuing at 20 to 30 weeks gestation. That being said, there is a case in which adalimumab was discontinued at 16 weeks of gestation, but it was still measurable at delivery in both the maternal and the umbilical serum 21 weeks later. So it's a little bit unclear if the pharmacokinetics of these drugs are actually a little bit different during pregnancy. There are a small number of clinical cases with pregnancy exposure to certolizumab, which is a pegylated TNF inhibitor monoclonal antibody, it was reported to have minimal transfer to the fetus, which is not surprising, again, because of the pegylation of the protein. There is very limited data on golimumab, and for this reason it's generally avoided. If you look at the pie charts, as I said, for the majority of these drugs, providers are using them if they're expecting at least moderate disease, except for golimumab because of the very limited amount of information available. Looking at the other biologic response modifiers, this table includes several biologic agents that most are reserving only for the most severe cases or not using at all. The data for these agents is much more limited, and the adverse pregnancy outcomes have been reported with abatacept. So you can see that for abatacept in particular, because of the reported issues with cleft lip and palate and heart and so on, malformations, half of the experts would not use it at all in pregnancy and the other half only in severe cases. I will say that there is a concern with rituximab, particularly for the concern with potential for neonatal B-cell depletion. We actually had a case where we had to give the mother rituximab while she was pregnant, and the neonate was born with no B cells. But eventually the B cells did recover, and fortunately the infant did not experience any infections. Looking at some of the other medications used in the management of rheumatoid arthritis, starting with the classic nonsteroidals, there is a small increased risk for spontaneous abortion, cardiac defects, oral clefts, and gastroschisis with first trimester exposure. With third trimester exposure, there are reports of persistent pulmonary hypertension of the newborn, constriction of the ductus arteriosus, oligohydramnios, and neonatal renal injury. Similar concerns, but with much less data, exists with celecoxib. And then prednisone has a very small increased risk of oral clefts following first trimester exposure. Probably the bigger issue with prednisone is its propensity for causing hyperglycemia. And we know that during pregnancy, women are in a state of insulin resistance, and the addition of prednisone can be problematic in terms of their glucose control. High glucose concentrations in the first trimester increase the risk for malformations, and in the latter part of pregnancy can cause macrosomia and the associated birth injuries. Probably the issues with respect to malformations in prednisone may be tied to its effects on glucose. So in summary, sulfasalazine, hydroxychloroquine, and prednisone are typically continued through pregnancy, although data is still limited. The TNF-alpha inhibitors provide a promising treatment approach, particularly for those women expected to have at least moderate disease. And lastly, the nonsteroidals are most safely used in the second trimester of pregnancy. So here's the second polling question. Which of the following medications are most likely safe to be used by lactating women? So during breastfeeding, the choices, and you should check all that apply, include ibuprofen, prednisone, leflunomide, tocilizumab, and tofacitinib. My screen went. Anyway, it's back. So go ahead and select one or more of those drugs as drugs that are most likely to be safe during pregnancy. I think that it gives you a little bit of time to choose your answers. So again, you're looking for those that are most likely safe during lactation. So 96% of you said ibuprofen. That is a good choice during lactation. Extremely low amounts are excreted in the breast milk. Prednisone, half of you thought, 46% thought prednisone was okay. And actually prednisone is also a drug that's okay to use during lactation. The other three, due to limited data, probably are on the list to be avoided or at least take careful consideration before using during lactation. Here are my slides back. Oops. Okay, so now moving to lactation. And we're starting off with the non-biologic agents. The table provides information on the most commonly utilized rheumatoid arthritis medications, whether they are detected in the breast milk, a summary of safety information, and then again, expert opinion on their use during lactation. Starting with hydroxychloroquine, it is excreted in very low concentrations in the breast milk. A small number of infants that were followed for 1 year during breastfeeding showed no adverse effects on, pardon me, on growth, vision, or hearing. So it is typically considered to be compatible with breastfeeding. Sulfasalazine and its active metabolite, mesalamine, are excreted into breast milk in low concentrations. However, high breast milk concentrations of N-acetyl 5-acetylsalicylic acid are reported. Its effect on the nursing infant are unknown. Another sulfasalazine metabolite, sulfapyridine, also appears in the milk and infant serum. There is a single case report of bloody diarrhea and a few cases of diarrhea without blood that have been reported with sulfasalazine or mesalamine. And most experts consider the mesalamine derivatives to be safe during breastfeeding. That being said, if sulfasalazine is required, it would be prudent to monitor the infant for diarrhea. There's no data available on leflunomide in breast milk, so it should be avoided during lactation. And lastly is methotrexate. It is excreted in breast milk in low concentrations, in extremely low concentrations actually. The milk to plasma ratio is 0.08. Historically, due to concerns that methotrexate may accumulate in neonatal tissue and interfere with cellular metabolism, its use during lactation has been avoided, with a week washout period being suggested. However, because of the extremely low exposure, some authors have concluded that low single or weekly doses, such as those used in ectopic pregnancy or rheumatoid arthritis, are of low risk to the breastfeeding infant. If methotrexate is used during lactation, infant monitoring of their CBC and differential would be a good idea. If you look at the expert opinion from the European League Against Rheumatism, there 2/3 of the experts would avoid methotrexate altogether during lactation, and the remaining only in the case of expected severe disease. Moving to the TNF-alpha inhibitors, there is limited information, but it indicates that maternal adalimumab, etanercept, and infliximab injections produce very low levels in the milk and do not adversely affect the nursing infant. Because these are large proteins and the amount in milk is unlikely to be absorbed to any significant extent because of the infant's, the acidic environment of the infant's GI tract. Even though the manufacturers recommend against their use, most experts say that these are probably safe during lactation. And if you look at the pie charts, you'll see that the majority would use them as if the woman was not lactating or reserved for moderate to severe disease, depending on the expert. Preliminary data indicates that certolizumab is not excreted into breast milk, which would be expected. Again, this is the pegylated antibody, and again, like you would expect with adalimumab and etanercept and infliximab, you'd expect it to be broke down in the infant's GI tract. There's no data on golimumab, but it too, being a large protein, is most likely to be safe during lactation. Looking at other biologic response modifiers, there's limited or no information available on those drugs listed in this table. During breastfeeding, they are large protein molecules, as are the TNF-alpha inhibitors. You'd expect only small amounts to be excreted in the breast milk, but because there is such limited data on these agents, they probably should be reserved for or should probably only be used with caution during breastfeeding, and an alternate may be preferred. Anakinra is a recombinant interleukin-1 receptor antagonist. There is IL-1 receptor in normal breast milk, where it may play a role as an anti-inflammatory agent. There's no data on its excretion into breast milk, but there are several infants that have been exposed via breast milk with no obvious adverse effects. And in looking at the table, you can see that the vast majority of experts reserve these drugs for those with expected to have severe disease or not use them at all. I think as data improves and increases in quantity, these agents perhaps will become more commonly used during lactation. Other medications for lactation, starting with non-steroidals. Ibuprofen has been the preferred analgesic and anti-inflammatory agent in nursing mothers because of its extremely low concentrations in the breast milk. It has a short half-life, and the amount that goes out in the breast milk is known to be safe in the infant. Naproxen is also excreted in low amounts into the breast milk, but it has a longer half-life, and therefore on the infant side of things, less desirable, although on the maternal side of things, having to take their doses less frequently, it may be more desirable on the maternal side. Most experts use the non-steroidals in the same way as in non-lactating women. Some reserve it to only those with expected moderate disease during lactation. The data on the other non-steroidals besides ibuprofen and naproxen is fairly limited. Celecoxib is also excreted into breast milk in low concentrations. It's most likely safe during lactation as well. And lastly, prednisone, which is excreted in low amounts into the breast milk, as is its active metabolite prednisolone. There are no infant adverse effects that have been reported in nursing infants. There are reports of high doses of other corticosteroids, not prednisone, and certainly not at the doses that we're using in management of rheumatoid arthritis, but have been shown to reduce milk supply. So if you have a woman that is having challenges with that, you might consider the prednisone as a potential contributor. In summary, ibuprofen, prednisone, sulfasalazine, and hydroxychloroquine are safe to use during breastfeeding. Preliminary data suggests that the TNF-alpha inhibitors are also going to be safe during pregnancy. They do have limited transfer into the breast milk. Data with methotrexate is controversial. It has very low transfer into breast milk, but most experts are still considering it contraindicated during lactation or reserving it for only the most severe cases. And other biologics appear to have limited transfer but have not been studied in sufficient quantity to tell us that they're safe. And there's little data available on the clinical use of tocilizumab during pregnancy because it's a large protein molecule and the amount in milk is likely to be low, absorption poor from the infant's GI tract. Eventually we might find that these drugs are safe. There's no data on leflunomide or tocilizumab, so they should be avoided. And then we'll move on to the case, and Megan's going to take over from here.
Great. Thank you for that really excellent review of all the medications and the safety there. So now we're going to take all the information we just gave you and sort of put it into action for this patient, Gina, who is a 28-year-old woman who's never been pregnant before, but she's had rheumatoid arthritis for the last 4 years. She's currently managed on methotrexate, which we use generally weekly, so they only take it 1 day per week, usually orally, though sometimes patients will take it subcutaneously, and adalimumab, which is Humira, and is taken every other week as a shot as well. All of our patients who are on methotrexate will also be taking, generally in the U.S. at least, they should be taking folic acid 1 milligram every single day to help some of the side effects from methotrexate. So her rheumatoid arthritis has been stable on this regimen for the last 18 months. She recently got married and is considering pregnancy. And so she comes in really kind of wondering what she's supposed to do now. So there's several things that you can advise her at this point that I think would be really helpful for her to get more information, but also to have a safe pregnancy. So first off, I would recommend that she see a fetal medicine, maternal fetal medicine specialist in order to be assessed for her pregnancy risks, but also to have a local obstetrician who is comfortable with the medications that we use for rheumatoid arthritis. The maternal fetal medicine physicians generally see patients on our medications much more frequently than other obstetricians, and so that usually smooths the road. Next, it's important to talk about the risks of methotrexate, and that it can increase the risk of pregnancy loss up to 40% and increase the risk of birth defects, potentially up to 7 or 10%. So this medication needs to be stopped, generally 3 months prior to conception. And I always have my patients just stay on their folic acid even if after they've stopped their methotrexate. She wants to know about her medications and the safety, and I think it's fair to reassure her that adalimumab is considered to be quite a safe medication in pregnancy, and she can work with her rheumatologist and obstetrician and MFM doctor in more detail to get that. One of her questions is pretty much always, how long do I have to wait until I can get pregnant? And that's really to get past the 3 months of methotrexate, period of methotrexate. She can certainly continue her folic acid and start a prenatal vitamin at this time. I'm trying to change the slide. There we go. So 1 year later, she shows up and she is now pregnant. She is 12 weeks along. Her disease is controlled with the adalimumab, which she did continue, and hydroxychloroquine. And she has a plan to stop adalimumab coming up. So as we discussed before, the methotrexate has been stopped, and it has been replaced in this situation with hydroxychloroquine. What we often find is that if a woman is requiring both methotrexate and adalimumab, or really any 2 medications to control her rheumatoid arthritis, if we stop the methotrexate, then often she will flare. As we talked about earlier, that will make it harder for her to get pregnant. So often we replace the methotrexate with an oral medication. Hydroxychloroquine is a great choice. Sulfasalazine is our other choice. So we usually replace the methotrexate with one of those 2. And then we continue the adalimumab. She's concerned about breastfeeding postpartum. And at this point, I think we can tell her which medications are safe, which we just heard about. So ibuprofen, prednisone, sulfasalazine, and hydroxychloroquine are all really considered very safe in pregnancy. TNF inhibitors like the adalimumab are also considered to be pretty safe at this point. The data we have suggests minimal, if any, transfer across the placenta, and it's assumed that those medications would be digested by the baby's GI tract, just like they are in the grown-up. If her concerns come to be about disease activity, which is frequently a concern, then we have some other options for her. So, I'm sorry. So she stopped her adalimumab at 30 weeks as planned, right? So that way she has another 8 to 10 weeks of pregnancy without the adalimumab, so that has gotten out of her system, and therefore, though it is transferred across the placenta at week 30 when she takes it, by week 38 there's minimal amounts in her system and therefore minimal amounts in the new infant. But during that time, often women will start to have more arthritis. So it's important that she gets started on the adalimumab quickly. And we do this for 2 reasons. One is, as I said, some women have already started to have some disease activity while off the medication in that last trimester. That's not that unusual. But also women have postpartum flare. So we talked about that a lot of women do improve in pregnancy but worsen afterwards. So worsening afterwards, what we found can actually be largely prevented, and that is by getting people back on medications quickly. So she had continued her hydroxychloroquine throughout the pregnancy, and she restarted her adalimumab, I usually do a week after vaginal delivery or maybe 2 weeks after a C-section, just so that the mother is healing, and from an infection standpoint from the mother is really the only reason to delay it. And she can take some ibuprofen as needed. In addition, she can take acetaminophen if she would like to, though most of our women with rheumatoid arthritis don't get as much benefit from acetaminophen as from ibuprofen. She's concerned about flare. Most of our patients are concerned about flare because they've read all these horrible things about it on the internet. And so I think it's worth reassuring her is that we do have options if she starts to flare postpartum beyond even what she's on. The first thing that we usually use is prednisone. So if she starts to have her joints flare up, she can take prednisone. Pretty much any dose of prednisone is okay with breastfeeding. Particularly if she's on very high doses, like 60 milligrams a day, which would be pretty rare with rheumatoid arthritis, she can delay her breastfeeding a few hours after her dose, and there'll be minimal amounts in the breast milk. So for women with rheumatoid arthritis, a more typical dose might be 20 or 30 milligrams a day, or it might be like a Medrol dose pack. And those would be fine to give a patient who's breastfeeding to help get her rheumatoid arthritis under control. It's particularly useful. Some of our patients don't really believe us that they really need to get back on the adalimumab because they're not feeling so bad, but it will come back, and prednisone might do a nice job of getting them under control quickly while the adalimumab or whatever their medications are. In addition, methotrexate might be an option, though most of our patients, we usually have them will stop breastfeeding before going on methotrexate. But that is an option for some of our patients who really just aren't well controlled without it. They will make that choice. But often we can get them a good 6 months of breastfeeding before they need to go on methotrexate. And with that, we are open for questions.
Great. Thank you both for that excellent presentation. We will now start answering your questions.
So I think the first question on there would be best answered by Megan.
I'm trying to see it. Can you read it to me?
Would you recommend immediate insertion of a LARC method postpartum for a patient with RA? Why or why not? Oh, it must be why or why not.
Yeah.
You recommend
So I think that putting in LARC soon after delivery for women with rheumatoid arthritis would be very appropriate if that's what she would like to do. I wouldn't have any different consideration for patients with RA as I would for any other patient, any healthy patient that you were seeing in terms of contraception at that point.
The next question says, prednisone and side effects during lactation, any studies focused on mood of baby? Anecdotal, but I felt prednisone while nursing made my kid freak out, irritable, fighting more, etc., which stopped with medicine change. So the amount of prednisone that's actually and prednisolone that are actually excreted in the breast milk are very, very low. It sounds from your experience that time-wise that it appeared as though it was being caused by the prednisone, but it may just be coincidental that there was resolution after your medicine was changed, because really the amount of both prednisone and prednisolone that has, based on literature reports but also based on my own research that hasn't been published yet, shows very, very low amounts that should not have a pharmacologic effect on the nursing infant. So a very unusual situation you're describing there.
Great, thank you. And I think we have time for one last question from Colleen. And she asks, what doses of ibuprofen do you find RA patients need?
So many of the RA patients really need high-dose ibuprofen. So when we think of ibuprofen at like 400 milligrams per dose, we think of that as sort of hitting the pain centers, but not so much working as an anti-inflammatory. When we get higher to 600 to 800 milligrams of ibuprofen, that's really the dose that seems to do both pain as well as some of the anti-inflammatory effect that people like NSAIDs for. So our patients, I pretty much routinely prescribe 800 milligrams every 8 hours with food is how we usually dose the ibuprofen.
Great, thank you so much. Megan, would you like to review the key points for us?
Absolutely. So I think that the key points from today is that there are some medications for rheumatoid arthritis that are teratogenic. Really the only one that we talked about today that we know is teratogenic is the methotrexate. Really most of our old other medications like sulfasalazine, hydroxychloroquine, and prednisone and so on are not particularly teratogenic. And our TNF inhibitors, which now have been around for about a decade or so, are also don't appear to be teratogenic, but we just don't know a lot about the newer medications. The importance of disease control prior to conception is really key in order to help people actually get pregnant. Planning pregnancy is key so that patients can get on appropriate medicine and not be on methotrexate when they conceive. Effective contraception and preconception counseling are essential in order to really make this happen so that we don't have accidental pregnancies on methotrexate. And certain medications, in fact many medications, can be used safely in pregnancy and lactation. And I really think that's an important message to give to your patients, that they just don't have to stop all their medicines in order to get pregnant. There are really good options available to them, and that they just need to work with their physicians in order to find those for them. And with that, I think we're just about finished.
Great. Thank you again for joining us, Drs. Mary Hebert and Megan Close. Before we end today's webinar, I'd just like to note that this session is made possible through an independent educational grant from Pfizer. Please be sure to visit arhp.org to view the previous webinar in this series on RA and the female patient. As a reminder, you will receive an email from Caitlin Borslitz in about an hour containing a link to the post-test survey. Your CME or nursing e-certificate will be generated at the end of that survey. Be sure to print the certificate before closing the internet browser. If you have questions regarding the CE process, or if there was a question that you wanted to ask that we didn't have time for today, just feel free to email us at education@arhp.org. Thank you again for joining us today. We hope you will take part in other live and on-demand sessions hosted by ARHP.